not running the assumption that these are what we need to per se.
No, I'm just showing you different examples of what the QRS complex could look like, which could be any number of different things. And remember when I said, I need you to break away from TV land? I need you to stop thinking that this is what an EKG has to look like. It doesn't. And some of our leads, if it looked like this, for example, if this is what our QS complex looked like in lead V1, something's wrong with them.
Or we misplaced the lead.
Or you did something wrong with the lead. Let's assume that that's not the case.
We prayed.
And we see that something would be wrong in that lead. And so I need you to get, I need you to open up to the idea that these waveforms mean something in relation to directional flow of electricity compared to where the cameras are. But depending on which camera we look at, tells us whether or not it's normal or abnormal.
And that's what you were saying with the QS versus an R wave.
Yeah.
It's just remembering what you're looking at.
Yes, it depends on where you're looking.
Okay.
Okay.
Awesome.
Okay. All right. Are we getting someplace?
We're moving.
Okay. The Q wave may not mean anything, or it may mean something very important. It may not mean anything, or it could be of critical importance. Okay. If the Q wave is 0.03 seconds or wider, meaning from the start of the Q wave to the end of the Q wave, if the time it takes for the Q wave to start and end is greater than 0.03 seconds, which is basically one little box, which is 0.04 seconds. I'll come back to the timing of that a little bit later. But if it is greater than 0.03 seconds, then we would say that Q wave is pathologic. It's a bad Q wave. Or if we have a Q wave that is equal to or greater than the height of the R wave.
That means what?
If we have,
It's erasing, dude. It's
Damn, Mons.
Mons just wants to learn so
Love
fast.
yourself.
if we measure in millimeters and our Q wave, if our Q wave is greater than or equal to a third of the height of the R wave. So if the R wave, if we're working in thirds, right? There's the height of it. There's 1/3 the height of the R wave. If this Q wave is greater than that height, if it goes deeper than the R wave goes up this direction, then that's also a pathologic Q wave. In other words, if we have a Q wave, it should be small and should not take very much time. So if it is a wide Q or a deep Q, it's pathologic. It means something bad. That make sense?
Any other situation, it's normal.
Normal equals 0.5.
In other situations, when you see a Q wave, it can be, if it's smaller than that and not wide, then it's just a normal function in that camera view,
Regardless of the camera view.
regardless of the camera view. Although some cameras show Q waves and some typically don't.
Correct, but it doesn't, if we see one, it doesn't matter.
No, not unless it's, but if you see one in those waves, in those cameras that don't normally show it, it's because it's going to be pathologic almost always. Otherwise, it wouldn't be there.
So we don't know that yet.
No, but you will. Yes?
When you're talking about being pathologic, you're talking about it being actively detrimental to your patient?
No.
Or are you talking about it being indicative of
Yes.
something
The latter. So here's the deal on Q waves. Q waves are normally found in leads 1AVL and V6 most of the time. That's where we see them physiologically. And that's because those show you how the septum innervates, and the directional flow of the septum is that direction, and lead 1 is over here, and so it's negative to lead 1. And the septum usually depolarizes first, which is why we see that Q wave there. And that's physiologic. Pathologic Q waves are indicative of a myocardial infarction that has already occurred. So those of you remember your, what's it called, medical terminology? myocardial infarction. What does myocardial infarction mean in medical terminology? Pertaining to heart muscle, death. That's right. That's what myocardial infarction means. That is a huge misnomer as a clinical thing. When we say somebody's having an MI, if we follow the medical terminology here, we would infer that their heart is dead. And that is not the case in an MI. When someone is having an MI, what we are saying is their heart is dying, but a person that is dying is not dead. Does that make sense? And somebody who is dying has the ability to not die, depending on what steps in and helps them out, right? If you are dying from blood loss, but we transfuse you and get control over that, perhaps tomorrow you're alive and you're no longer dying. Does that make sense? Somebody who is dying of blood loss that doesn't get transfused will wind up dead. They're no longer dying. They're dead. Does that make sense? In medical terminology, this makes us kind of infer that their heart is dead, but that is not the case. An active MI means that their heart is currently being injured and will be dead if an intervention does not happen to protect from that.
And that can also show a past MI, right?
So, hold that thought. Okay? Does this make sense?
Yeah.
Okay. Our ability to tell if somebody is currently having an MI and therefore their heart is dying but not dead is related to the ST segment. I'll come back to that later. The ST segment. But if we were to see a pathologic Q wave, then it means that there is a portion of their heart that is dead. Because it is dead, we can't say when it died. It could have died just 30 seconds ago, or it could have died 30 years ago. We can't tell when it died. We can just tell that it is dead. So we see this in a lot of diabetic patients, where you'll have a diabetic patient, and diabetic patients, type 2 diabetics, can be very complex, and they have a lot of pain. They've got a lot of problems. They've got a lot of neuropathies that prevent them from feeling certain things. They've got a lot of problems. And it's reasonably common for a type 2 diabetic that's been a long-term type 2 diabetic to go get a checkup or go to their doctor having not gone for many years, and then they go to their doctor and they get a physical. As part of that physical, they do an EKG, and the doctor might come in, their doctor might come in with EKG and say, so when did you have your heart attack? And they're going, I didn't have a heart attack. What are you talking about? But they can absolutely tell, because we can see not only that they had a heart attack that did result in death, we can tell where that death happened by seeing the Q waves. But we wouldn't be able to see when they died, when that portion of their heart died. We couldn't give a time to it based on Q waves. We can just tell that it is there. Unless you have serial EKGs. EKGs over and over again. So for example, if you had an EKG on scene, when you first arrived on scene and didn't see any Q waves, but you saw that they were having an MI, and you're treating them for an MI, and in the portion of your transport you did another EKG and see Q waves, those would be new onset Q waves, and you know that their heart just died. Right? A portion of their heart has now died.
A 0.03 or wider or greater than 1/3 signifies death.
Yes.
Non-recoverable?
Yes. Dead is not able to come back from not being dead. You're dead. It's no longer living.
It is no longer dying. It's just not out
That is
there.
correct.
Okay. So bad QAs, bad death. Death.
It is dead. Right? I don't know if there's good death or bad death, but it's dead. And once it's dead, you're not going to get it out. Now, I will say there are some times that we'll talk about pathologic Q waves that aren't related to the heart, but we'll be specific on those. So for example, there are some leads that'll show you a pathologic Q wave in the context of a pulmonary embolism. But that'll be very specific to that patient and something that you would expect to see that doesn't follow the rule, and there's reasons for that that we'll discuss when we talk about that issue.
So, could I just see the pathological Q wave in one of those in lead one?
Yes.
Will it present the same in lead one, AVL, and V6?
Uh,
Or will it sometimes just show up in one of the leads?
So lead 1 and V6 will often show it well. AVL is a little bit higher, so it just kind of depends on where that was. Leads 2 and 3 would come together to showing things, or AVF and lead 3 would often show you the same things. So I wouldn't necessarily say that if I saw it in one lead, oh, that's definitely it. I would want to see it from a different camera angle as well, just to make sure there's not an anomaly with that one lead. So either I want to get serial EKGs that keep showing it, or I see it in 2 different cameras. And remember when we took pictures of, Dustin, was it you that we sliced up?
Yep.
Right? And remember we had several cameras that were looking at that same picture, and some cameras showed it really well, and other cameras didn't show it really well, but they still showed it. So I would see Q waves in both of those cameras, one that would be more significant than the other, but the other would still show it significantly. Does that make sense? So I would see a couple different camera angles that would show the same thing. Rarely would I see it only in one. Make sense? Yeah. So those are our Q waves.
What?
And so significance in the Q
I
wave
know.
greater than or equal to 0.03 seconds, or greater than 1/3 the height of the R wave.
I know, I stuck.
Would tell you that it's
It kept
significant.
falling off, and then
You're
when I put
defining
it down
the
there,
Q
it's
as
over.
when it
Yeah.
returns to baseline.
Yes, so I would find where my baseline is and see it. And the thing is that you inherently might have some disruption in the EKG that makes it difficult to find when that happens, but you'd still be able to see the time and you'd still be able to see the depth pretty easily. It becomes more easy to see those pathologic Q waves. And really, when you're looking at the Q wave, if you see daylight inside the Q wave, it tends to mean that it's, yeah, the ink usually runs it together where you don't see much more than just a crack at the top between the two. So when you see that widen out, you start, oh, okay, let's measure this Q wave.
So larger Q wave, like you said, is indicative of a past MI?
Correct.
So you wouldn't see that, like, if you keep doing, like, 12 lead after 12 leads, like.
No, you might.
You might.
So it's indicative of dead tissue whenever it died.
No.
So, for example, if you have a patient that is currently going through an MI, and their heart is pretty progressed in that MI, and you're doing serial EKGs, it's quite possible that that tissue does die on your watch, and you will see the Q waves form on your EKG. Between this EKG and the next EKG you took, you might have had those formations of those QRS complex. In which case, you now know how old that death is because you've been doing serial EKGs. But if we were to pull that one EKG that showed the Q wave out of the mix and hand it to somebody, they could not tell you when it happened. You'd have to have the rest of the case to determine when it happened.
Follow up to that. So why you said type 2 diabetics this can happen to? They have no idea they've had a heart attack?
The
or is
the
that
only
just-
thing I was referring to with type 2 diabetics is that sometimes they don't feel the heart attack happen.
Oh, okay.
This is not indicative of type 2 diabetes.
Okay.
This is indicative of heart death. And I was just giving an example of a patient that sometimes sees those Q waves form without even knowing that it happened.
Would
Bless
you
you.
see in serial EKG, would you see the Q, for instance, if it's getting longer or deeper and deeper and deeper? Would you notice that?
Only if there's more and more and more death happening.
Okay.
Once it's dead, it's dead.
Okay. So
Right? So the only way that it would ever change the depth or the width of that Q wave is if there was more tissue in that surrounding area that died and was no longer. So remember that the depolarization of tissue only happens when it's alive. It doesn't happen when it's dead. Yeah, it's amazing. Dead tissue doesn't depolarize.
Right, so why would you see it then and it wouldn't produce nothing?
What a fantastic question.
Like, why would it even register
So,
electrically if it's
so
dead?
here's the question. The question is, in a Q wave, why would you see anything at all? Because the tissue is dead. And a follow-up to that has nothing to do with that, but a secondary question is, a question that Annalise asked, which was awesome, and that is, if the TP segment is negative for a P wave that's positive, but the QRS is positive and the T wave is positive, that doesn't make any sense, does
Yeah,
it?
what the heck?
Come back to my next EKG class.
No.